Yeah, good good afternoon, everybody. Dear Professor Nguyen, dear Dr. Nguyen, dear professors and colleagues in Vietnam and Germany, it's a great pleasure for me to be again part of this interesting German-Vietnamese collaboration and association, and to give a lecture here at your Heart Association Congress in Vietnam. First of all, I would like to thank Dr. Nguyen for the kind introduction, and I want also to thank him for the great partnership we have together at the St. Vinzenz-Hospital in Cologne together. And now it's my pleasure to give a talk about a percutaneous treatment of 3 vessel and left main disease, state-of-the-art 2021. So the first question is, who did the first left main PCI, who invented it? And it was back in 1977 in Andreas Grünzig's times. And the 4th patient he treated by PDCA was actually a left main patient, as you can see here, and with a very nice final result. I mean, of course, this was in the pre-stent era, and things changed a lot since then. So pictures say more than 1,000 words. Let's start with an example from clinical routine. Here we have the coronary angiography of an 81-year-old gentleman suffering from NSTEMI. And as you can appreciate here in the proximal LAD and also in the part of the left main, we have severe calcifications, and this makes up together for a syntax score of 32. So what to do now with this gentleman? Let's ask the European guidelines. As you can see here, there are several options and ways how to decide if a patient should undergo CABG or PCI. At the end of the day, our patients with a syntax score of 32 and a left main stenosis has a 2A recommendation for PCI. But at the end of the day, the heart team should be considered, and also the patient has to be adhered if he or she does want to undergo a CABG or not. So this is a very important point in this discussion. And here you can see the German consensus on the guidelines, and our patient would be a 2A recommendation for PCI. But if the syntax score would be only 1 point higher, then we would have a 3A recommendation. So we should not treat this patient with PCI. But as you have seen, with the age of 81-year-old, and he was very frail, I think there's no doubt that after heart team discussion, this is a typical PCI patient. But to start with, what evidence do we have for 3 vessel and left main disease in these times? The mother of all studies was the syntax trial. And here you can again see the 1-year results published 12 years ago in the New England Journal of Medicine. And as we can see here, after 1 year, there was no mortality difference between PCI and CABG in coronary artery disease patient, also not regarding stroke or MI. But as you can see here, and as we all know, there was a tendency for significantly higher repeat revascularization in patients treated with PCI. But what happened after 10 years? And here you can see the continued syntax 1 study, and here we can see the Kaplan-Meier curves for all-cause death. And only 3 diseases, this is the only subtype that remain with a significant mortality difference over 10 years. Even patients with diabetes, there was no mortality difference between PCI and CABG, and also for left main patients, as our patient here in this example, there was at least no mortality difference. What can we do if we don't have enough studies to find a valid answer to these questions? Then we can do a meta-analysis. And here we have a very nice analysis from the Lancet 3 years ago, published about 3 vessel disease. Here you can appreciate taking 7,000 patients from 11 randomized controlled trials that we have a mortality difference after 5 years. But again, if we do this meta-analysis with more than 7,000 patients from these RCTs regarding the subtopic left main disease, we don't have any mortality difference after 5 years, as we have seen in the 10-year syntax 1 trial results. So what we do have to ask ourselves is if these trials still represent standard of care. If we go a little bit deeper into the study data, then we have to admit, and we see that syntax score was used to quantify disease complexity. In most of the studies, you can see in these meta-analysis, early generation drug-eluting stents have been used that we would never use in these times. There was a very low rate of FFR or IFR guided strategy. We had a low rate of imaging guided PCI optimization at the end of the day. And the rate of complete revascularization was quite low, only 57% in the PCI arm of the Syntax 1 trial. And what we have to talk about is that only low-risk patients have been included in these studies, and these higher-risk patients we have to deal with in our clinical daily routine haven't been included. So I think I don't have to say anything more about the syntax score. If it is still appropriate for decision-making in these times, that's a question we have to ask ourselves. I mean, it was introduced by the Syntax 1 study group more than 10 years ago to quantify disease complexity and to quantify coronary anatomy. But if this is enough in these times based on angiographical assessment only, that is a major question. And just one example for the benefit of next generation drug-eluting stents that are clearly superior to early generation DES was the SPIRIT 4 trial, even also published 11 years ago. And as you can appreciate here, benefit of almost 40% regarding MACE. So that was a lot better than the paclitaxel stents used in the taxol stents used in the Syntax 1 trial. And if we take a look at FAME1, a study that evaluated an FFR-guided PCI strategy to compared to angiography guidance only, we also see a clear difference with a reduction of nearly 1/4 regarding MACE. And even in this study, mortality could be significantly reduced by 42%. Another thing we learned from the FAME1 trial is that angiography alone is inaccurate in assessing the functional significance of coronary stenosis when compared with FFR. And as you can see in this nice diagram, is that stenosis between 50 and 70%, only 1/3 is functionally significant when measured with FFR. And this part increases if the diameter stenosis also is higher in patients. And I mean, there's no doubt that a stenosis above 90% diameter stenosis has not to be evaluated by FFR, but especially these intermediate stenosis are very often false positively assessed by the operator if only assessed by angiography. And what this study showed is that patients with angiographic 3-vessel disease, and these have been 509 patients, at the end of the day, only 46% had functional multivessel disease with more than 2 coronary arteries assessed with an FFR below 0.80. Another thing that hasn't been included in these older studies that I've shown to you is that intravascular imaging decreases the rate of target vessel failure. And as we can very nicely see in this ultimate trial published 3 years ago by our Chinese colleagues, the use of IVUS in PCI optimization was able to reduce the MACE rate by almost 64%. And taking all these strategies together, newest generation drug-eluting stents, FFR, IFR guided strategy, IVUS for optimization of PCI. This was included in the Syntax 2 trial, a single-arm study that was matched to the Syntax 1 PCI arm. And as you can see in this Kaplan-Meier curve, I mean, it wasn't a randomized clinical trial, but if we can see and compare the Syntax 2 arm with the Syntax 1 PCI arm, we have a very highly significant reduction of MACE by 42%. So taking all of these studies together, we can see here, if we treat our patient with a modern strategy as done in the Syntax 2 trial, we have a 1-year MACE rate of 10.6%, what was lower than the cabbage MACE rate in Syntax 1, and that was even lower than the PCI FFR arm MACE rate in the FAME trial. So what is the reality? What can we see in clinical daily routine? And this study from the US New York State Registry is very nice because it clearly shows that if you do a propensity score matching in more than 18,000 patients with triple vessel disease, then you can see that there's no significant difference regarding death. PCI was superior regarding stroke. That is nothing we are really wondering about. But as shown in the other studies, there's a higher myocardial infarction rate in the PCI arm. How can we explain this fact? If you take a closer look at the effect of completeness of revascularization, then there is a clear and significant association between incomplete revascularization in PCI patients and the recurrence of myocardial infarction during follow-up compared to the cabbage arm. So if we completely revascularize our patients with PCI strategy, then this is the conclusion of the study, the myocardial infarction rate shouldn't be that different. So if you take together in another meta-analysis these modern studies and take a look at the risk of mortality in left main patients, then there is no difference anymore between PCI and cabbage. And we still have this significant difference regarding unplanned revascularization, what in my opinion isn't that issue if a patient has to undergo another intervention that is not bad for the patient as compared to stroke or the decreased mobility after an open heart surgery. So taken together, the heart team has to be the gatekeeper for the decision-making and the strategy that is appropriate for the patient. On the one hand side, acute illness with a STEMI patient or cardiogenic shock that clearly favors PCI strategy, while a unsuitable coronary anatomy with a high syntax score, multivessel disease, diabetes, or a distal left main might favor cabbage if the patient is stable. And especially we have to take into account for PCI strategies, as in my example that I'm going to show you next, is the frailty the patient brings with him and the other comorbidities. And we have to keep in mind that, as I said in the beginning of my lecture, that only low-risk patients have been included into all these randomized controlled trials with a logistic Euroscore of about 2 to 4, that is quite low, as we all know. So that has to be kept in mind. Our patient here that I've shown to you in the beginning has a logistic Euroscore of 14, so it's clearly a high-risk patient. And if we take a look at the syntax 2 score, then the treatment recommendation, even from this score, even though it is quite complex coronary anatomy, is that we should go for PCI. And I would like to show you in this example, intravascular imaging for strategic planning and sizing of the stents to show how a modern PCI strategy can work. First of all, we use IVUS for a step 1 evaluation of the lesion significance, and if the minimum lumen area is above 6 millimeters square in a diseased left main, then this patient is safe for deferral. We don't have to treat this lesion. If it is below, then we should go for PCI. We can characterize our lesion. We can see severe calcifications, differentiate that anatomy from thrombus dissection or neointima proliferation, stent under expansion, and these things. Then in step 3, we can evaluate the vessel diameter and lesion length, especially the distal reference diameter is here quite important, as we can do a POT to optimize the proximal part of the stent. And finally, step 4, the assessment of implantation quality. And we can see in the IVUS if there is strut malapposition, stent under expansion, or edge dissection. So if we evaluate the distal left main of our patient, then we can clearly see that there is a Medina 111 situation. As you can see here from the diameters, the ostial LAD has a minimum lumen area below 4 millimeters square. The distal left main is below 6 millimeters square, and the ostial circumflex artery is even below 2 millimeters square. So there's no doubt, I would say, that this is a significant Medina 111 lesion in the left main. And if we further try to characterize our lesions in a step 2 evaluation with IVUS, then we can see here LAD stent in the mid-LAD implanted several years ago with a very nice result, optimally expanded. But if we go here more into the proximal part of the LAD, then we can see this napkin-like severe calcification and circular calcification. And this clearly will pose a challenge for lesion preparation in this patient. So I don't want to go too much into detail due to reasons of time, but what we have to ask ourselves in a patient like this is if we should go for one stent or two stent strategy. As you all know, the risk of a one stent provisional stenting strategy can be that you can lose the side branch, what would be a catastrophe if you lose the circumflex artery. But on the other hand side, a suboptimal result in a two-stent strategy will increase the risk for stent thrombosis and during follow-up also for restenosis. So what we have to keep in mind from many studies that have been published during the last years, and I just want to highlight the DK Crush 5 studies from China published 4 years ago in JAG, that if we have a complex lesion, as you can see here on the right, very similar to our patient here, then a two-stent strategy, basically and predominantly DK crush or culotte stenting, will lead to a benefit for the patient during follow-up, especially due to the fact that this will reduce the need for repeat revascularization. And as you can see here, the distribution of in-stent restenosis in a two-stent strategy arm was, if we go for provisional stenting here in part of the ostium of the side branch, the in-stent restenosis rate was quite higher than compared to a DK crush strategy, where we had only 5% compared to 12% restenosis rate. So here's the final result of our patient. And as you can see here, with a DK crush stent strategy after kissing balloons and POT, this looks very nicely and also has been assessed by IVUS at the end of the day, so that this patient will benefit from the interventional result. So, dear colleagues in Vietnam and Germany, dear ladies and gentlemen, I would like to summarize my talk, and the take-home message I would like to give to you for left main disease is the following: that PCI with new generation drug-eluting stents will lead to a similar outcome as CABG in terms of mortality throughout 5 years. We have, I would say, enough data for that conclusion. And you have to keep in mind that obviously PCI is associated with less periprocedural morbidity, less stroke, less periprocedural MI, acute kidney injury, and also major bleeding. But CABG is more sustainable at the other hand side. It's associated with a better protection from recurrent ischemic events after periprocedural period. There are less spontaneous myocardial infarction, and there's less need for repeat revascularization. But, and that is very important for the decision-making and also for the decision of the heart team, there are several factors that have to be kept in mind. Volume outcome relationship, the more left main PCI the center does, the better the result will be. Intravascular imaging and the appropriate technique will lead to optimal result and play an important role for left main PCI in clinical daily routine. And my take home for triple vessel coronary artery disease is that evidence is growing that mortality for CABG and PCI with second generation DES might be similar, and that there will not be a mortality difference in the future. And that therefore the decision about CABG or PCI and three vessel disease patients should be based on the ability to completely revascularize the patients, on comorbidities, how frail the patient is, and if the patient presents with acute or stable disease. The operators should weigh the short-term risk of death and stroke with CABG with a long-term benefit of reducing the risk of repeat vascularization and myocardial infarction. On the other hand side, the result might be more sustainable, especially in patients where you would need a lot of stents. But that's something we can maybe also discuss. Patient's preference is also very important for the decision-making. If the patient refuses to undergo open heart surgery, then I would say, and I would clearly say, we should offer the patient a interventional strategy after patient-informed consulting. And probably one study that will elucidate the situation a little bit better in the future will be the FAME3 trial, where an FFR-guided PCI strategy will be compared with an angiography-guided CABG strategy. And this study will include 1,500 patients. So we can be excited about the results that will come in the next years. And at the end of the talk, I would like to thank for your kind invitation to this very interesting virtual conference. And I'm open for your questions. Thank you very much.
Thank you very much, Professor Zinning, for this excellent presentation. And we have 5 minutes for discussion. So we'll open the discussion now.
Okay, I have a question. In your hospital, you use the machine or DSA or CTA to evaluate the FFR. Normally, you measure FFR on ESA or cath lab.
Yeah, that's a very important question and a very good point that you made. In our hospital, we basically use FFR, invasive strategy for FFR and IFR. I think we are not quite there already that we can use CT angiography for FFR measurements. That might be the future, but probably I would say all of our patients that undergo heart catheterization and therefore an invasive strategy had a positive ischemia testing, or on the other hand side, that's something we're doing very liberally in our hospital. They underwent a CT angiography before they undergo catheterization. And if there's a very high calcium load with a very high pretest probability for coronary artery disease, or there are even stenosis in the coronary angiography, then these are typical patients. But to come back to your question, basically, and I would say in almost 100% of our cases, we only have an invasive strategy for FFR and IFR.
And on the other hand, for FFR on the CE, very expensive. I know the same in USA. Thank you for your answer.
Yeah, that is true. I mean, we have to talk in these days a lot about resources, and therefore our, I would say, main approach is that the patient undergoes ischemia testing before he underwent heart catheterization. And I'm also glad to have Dr. Bauer de Kock in my hospital, who was a very excellent echocardiographer. And most of the patients, they have very good stress echo. So if we can see there a hypokinesia under exertion, then we can skip FFR, IFR, and directly go for the PCI. But at the end of the day, I mean, that is quite privileged. Most of these procedures are reimbursed by the health insurance companies right now in Germany. So this might change in the future. We don't know. There's always a discussion going on, and the material and the catheters and the wires, the pressure wires, are quite expensive. But in these days, we can use it liberally. But just to give you an overview, only 12% in Germany of the patients undergoing PCI got an FFR measurement or IFR measurement before PCI. So that is, I would say, a suboptimal result regarding the resources. And for our hospital, the rate is quite higher. It's something about 25 to 30%.
Yeah, okay, the last question. Have you used CMR to evaluate the viability before stenting?
Yeah, that's also a very good question. Thank you for that. Especially, we're doing a lot of complex PCI and CTO patients with chronic total occlusions. And in these patients, if there is doubt about viability in hypokinetic myocardial areas, then these are typical patients to undergo CMR before they undergo these very complex procedures. So that's also a privilege in our hospital that we have a CMR possibility available, and the head of the Department of Radiology is a very good friend of mine, so there's a very good collaboration in the clinical daily routine.
Thank you.
Okay, thank you very much, Professor Zinning, and Dr. Wang, for this great discussion, and then to be in time. It's a great pleasure for me to introduce Professor